Okay.
Boom.
Well, good evening, everyone. Thanks for joining us this evening. This evening we have Dr. Magda Stewart with us. She works alongside with Dr. Cooper Williams in the local Maryland area. I'm sure many of you know her. She's going to talk to us this evening about kissing spine. I'm recording this, so you will be able to get this recording later this week. I'll send out the link to our YouTube channel as well. We just ask that to mute yourselves as she's speaking. If you have any questions, you can put it in the chat or ask along the way. And I will hand it over to you.
All righty. Okay, so obviously kissing spine is a very hot topic. It can be a sore spot for some people, no pun intended. So we're just going to kind of start out with a little bit of basics on kissing spine. So one of the biggest things that I think you'll see through these cases is that you can't predict which horse has kissing spine. Some might be more obvious than others. Can everyone see my cursor? I'm guessing.
Yep, we can.
Okay, great. So some might be more obvious than others, but some might look perfectly rounded and well developed. So an exam is your best way to go. So kissing spine, does this mean the end of your horse having an athletic future? So this is a trigger diagnosis. A lot of people say that this is the hot diagnosis right now, and a major concern for many people during a pre-purchase exam. So it's estimated, if you read different papers and numbers, the average number that you find is about 39% of our horse population is said to have it. I do think that that number can be skewed depending on the breeds that you are examining and kind of the area of the world that you're looking in. But that's a pretty significant population of horses, and not uncommon to run across this in our athletes. Horses are 3 times more likely to have back pain with the dorsal spines process impingement, which is the official medical name for kissing spine. That being said, a horse is born with this abnormal conformation, and it's repetitive movement that leads to this dynamic condition that can cause clinical signs. And the hardest part about this disease is it's so variable in how these horses present. It can be difficult to predict if a horse will have back pain, when the horse will have back pain. Probably one of the more difficult parts, things that we do when a pre-purchase, is when somebody is buying a horse that they intend to have these big goals for, and the horse isn't even doing that yet. And you find things on their exam. It's difficult to predict as you increase the horse's training, as you're doing more with the animal, what may or may not become painful. So I always tell people that say, gosh, this horse has kissing spine on my pre-purchase. Question 1, is it clinical? Question 2, is the horse doing what you want it to do right now? And question 3, are you ready to manage it? And if you are, you know about it. And some of the things we'll talk about today will kind of help you guys be more prepared for those situations. And a big thing I just want to say is radiographs do not show active inflammation. They might diagnose the conformation being there, but doesn't tell you if it's a problem. As well as just spanning it back and reminding everyone that there are a lot more causes to back pain than kissing spine. There can be arthritis in the thoracic or lumbar joints of the back. You can have referral pain from other areas. You can have muscle tearing, et cetera, et cetera. So let's go back and start at the beginning. I apologize for all my puns. I can't help it. All right, so real quick anatomy, because I have to. We have 7 cervical vertebrae in the horse, 18 thoracic, 6 in the lumbar. This is the fused sacrum of the horse, and then the tailbone. So one thing I want you guys to notice is just the arch that the horse's spine makes. We think about their head. That's a significant turn that this horse's body makes. So it's why we have and why axial skeletal issues are so important. And one of the reasons I think kissing spine is becoming more and more talked about is because as we study biomechanics and are starting to get some of these CT machines and MRI machines, we're learning more and more about spinal disease and how it affects our athletes. So this is an anatomical picture. So you have your dorsal spinous process here. That's going to be a word that you guys are going to be sick of hearing at the end of this, and I'll probably just refer to it as DSPs. And then the joint for the back is all the way down here. So in the radiograph, it's all the way down here. And then the actual vertebral bodies are these blocks down here with your spinal cord running kind of between the articular facets and those bodies. All right, so this is a bone picture of what their back looks like. So when we refer in common layman's terms to the horse's back, we're actually talking about the thoracic and the lumbar usually. So, and then the one thing I want to note is it's very normal for a horse to have narrowing at the end of the thoracic vertebra. It's called the atlantoaxial vertebra. And so if you see that, you know, if that's the one spot that someone tells you you have the horse narrowed, that's actually normal anatomy for the horse. So you guys are gonna have to bear with me because I'm gonna get into a little bit of very basic biomechanics, which if everyone's reading all the current dressage and neck stretch core exercise forums and blogs, I'm sure you've run across this. So what I think is really interesting in the horse, when we think about bending their body, the majority of the bending, lateral movement, so side to side movement, comes from the neck and then comes from T10 through T16. So that is a really small part of this long spine of a horse that does the majority of the lateral movement. And the most common spot for kissing spine, statistically speaking, over all the ones that they've measured, is T13 to T18. So this is why one of the common causes for back pain when you're doing lateral movement can be this kissing spine condition. This is an example of a normal radiograph of a horse. So this is coming off of the withers, and this is your cranial thoracic area, or where the saddle sits, and you have nice spaces between each of these dorsal spinous processes. And that's a very normal appearance to the back radiographically. Okay, so this is where we'll go back to kind of just talking about movement through the horse's skeleton. So it makes sense that the neck can do everything. It can axial rotate, it can laterally bend, it can flex, it can extend. I think that goes without saying. And then if you look back here, you'll see there really isn't a lot of flexion and extension, and really no axial rotation. If there is, you have a problem in the horse's thoracic and lumbar area. And that makes sense. They're quadrupeds. They don't need to axial rotate like we do. You know, they don't need to be able to do a 360-degree turn with their spine like bipedals do. And then flexion and extension, for the sake of protecting their spine, is very limited through the long part of the back, and then recurs when you get back into kind of the sacrum and the sacroiliac, aka pelvic area, which does most of the flexion through the back of the spine. But you can again see the most lateral movement comes between T10 to T16. And this will play into how we diagnose and look at this. So when we talk about flexion and extension, the most that you actually see in the thoracic and lumbar areas, people that are doing all these biomechanical studies and measuring the axial skeleton in postmortem, et cetera, is 6 degrees. So if you think about how much we can flex and extend our back when we do cat-cow, the horse's actual skeleton is only changing 6 degrees on average in their thoracic and lumbar vertebra. So that seems like a small amount, but that small amount is what allows us to have all the differences between an engaged horse, a hollowed out horse, and a neutral spine. So this first radiograph, I think this is a really cool picture, but this shows a horse that just has a neutral spine. So the head is normal. It's not high, it's not low. It's just a normal head position of a horse. And then when you ask a horse to engage, aka lower the head, put it in a frame, what have you, this actually relaxes the long ligament that helps hold the head up, and another ligament that runs across the top of the spine. And I'll show some pictures of that in the next slide. And as a result of this ligament that runs across the top of this is relaxed, so there's not as much tension between each DSP. The abdomen becomes lifted, and your skeleton actually becomes more convex, aka the horse is engaged, allowing an opening of these processes. So this isn't a pre-surgery, post-surgery, this is a neutral spine, and then a horse that is being asked to flex its spine and engage. And on the flip side of that, when you have spinal extension, the head becomes higher. So this is a really nice schematic of that. So here this horse is lowering its head. The nuchal ligament is a ligament that runs from the back of the pole to the withers, and then it becomes the supraspinous ligament back through here. And that runs across their entire, and they work together to both lift the head, allow the head to lower, and allow extension through the back, and then relaxation allows flexion through the back. So with this, the head goes down, the nuchal ligament and the supraspinous ligament relax. The sternum and the abdominal muscles engage, so these muscles through here engage. And then your iliopsoas muscles, which run on the bottom of the spine and are represented by these lines here, contract and engage, and to help flex and engage the whole spine. When the head goes up, the nuchal ligament contracts, the supraspinous ligament contracts. You get a dropping of your thorax down and their chest down, and an unengagement of the abdominal muscles like the rectus abdominis. And as a result, your spine has more of a concave appearance, which leads to a decreased space between these dorsal spinous processes. So I think that's really important to know before you even think about kissing spine, and then can make sense of why this is considered a dynamic condition, and also why it can be so difficult to predict if, when, and what level of pain a horse might get from this kind of impingement. So if they're born with this abnormal conformation, so if we go back to these, if a horse is born with the normal conformation, these flexions and extensions don't create issues. But when we get these impingements, that's where you start to get interference that leads to changes that can become clinical. So now we're going to get into it. Dorsal spinous process impingement, aka the overriding dorsal spinous processes. These are all medical terms for kissing spine. And it's a conformational problem. They are born with kissing spine. And when I say kissing spine, I just mean that these spaces are decreased between each dorsal spinous process. And over time, the biomechanics that we just talked about, the flexion and extension and the opening and narrowing of that space, creates remodeling. These are some pretty significant examples. This is what we would call an overriding dorsal spinous process, where you actually don't have any space left. And then all of this is bone remodeling, kind of like spurs that we might call in a hock joint, but a little bit different in cases where these spaces are narrow. Okay, and why does that cause pain? So there is a tiny ligament that runs in between each one of these called the interspinous ligament. And that ligament originates and inserts between the two. At its insertion, it has a lot of nerve fibers. So if you have impingement, and if you have bone that is remodeling and active and inflamed, that ligament and the nerves associated it become inflamed. And the reason that back pain can be such a chronic condition until it's not, until it's active and it's hurting and the horse can't compensate, is because this leads to kind of a similar wind-up pain that we get in humans. And this constant nerve stimulation creates a constant influx of signals to the spinal cord that this is painful, this is painful, this is painful. And so you get this wind-up pain element to it. The secondary part to that is obviously this vertebra is not going to move normally if you have overriding processes like this. So you end up with secondary arthritis in the actual joints as well, just from abnormal movement and increased forces in that joint. These are the arthritis joints down, these are the joints down here, these little communications between each one. So cranial facet, caudal articular process, those two things together make the joint of the actual back. And you can see how this one's nice and crisp here. And then you kind of start to lose the crispness of your joints, really lost here. And then very wackadoo there, officially, that's official word. And then secondary to that, if you have a muscle that's sitting along these bones, obviously that muscle is going to be inflamed from an abnormal surface that it's lying against that should be nice and smooth like these, and instead is roughened from the remodeling. Okay. So we're going to jump into some cases later, and I hope that helps demonstrate my point that one of the hardest things about kissing spine is that it is highly variable how a horse will present. You can get anything from bucking when they pick up the canter, you know, they're very difficult to groom, kicking while grooming, don't like being curried, falling in around the turns, difficult at certain distances to the jumps, objecting to hill work, or even something as simple as the horse is just becoming very dull to the rider's leg. So overall, the most common presentation is poor performance. So a horse that was doing well is starting to show issues. That doesn't mean it's lame or doesn't mean that it can't be ridden, but is creating a decreased overall performance for what sport they are supposed to be doing or training they're going through. In general, kissing spine does not cause a unilateral lameness, but one of the things that I've heard from clients as a complaint that has then been diagnosed and proved to be caused by back pain is a shifting leg lameness. So people will say, oh, yesterday, you know, he felt wrong in this leg, and the week before was that leg, and the week before was everything behind. And so that can be one of the associated presentations for this. The second most common, and probably the more, you know, common part that we see on our examinations is true back pain. So they react when you run your hands down this dorsal midline through here. They actually react to that pressure. We always start with light pressure and then increase our pressure as we go so that you can get a gauge of what the horse's sensitivity is. They can be resistant or stiff to flexion and extension. So when you put pressure on their back, and then when you ask them to lift their abdomens by putting pressure underneath their belly, a horse might kick at you, might be evasive and shuffle away. They could be very stiff, or they could be very jagged in their movements. And then another test that we do is lateral mobility testing. And so if we think back to where the fact that the majority of the spine movement comes from T10 to T16, and then the most common locations for kissing spine overlap that, if we ask a horse to move around the midline when we're doing a lateral movement mobility test, and this horse is reactive to this as well, it can really help hone in pain to that specific area. Because when you're looking at, you know, everything from the withers through the pelvis on the horse, it can be really difficult to separate out thoracic, lumbar, and pelvic pain, or sacroiliac, lumbosacral pain, because all these muscles overlap They're all part of flexion and extension, as you guys saw in the biomechanics slide a few slides ago. So when you have back pain, you have to remember that it can be referral or it can be specific to the thoracic and lumbar area. And then another really common finding is you might have a really well-muscled horse, and then the area under the saddle kind of looks hollow. And it's a lack of the main muscle that sits along the back, which is a group that we'll call the erector spinae or the epaxial muscles. And sometimes they can be so poor muscle that you can actually see the tops of these bones in front of the croup. I apologize, my dog is being really wild in the background. Okay, so your horse is showing one or multiple of the signs that we mentioned above, and you're concerned about kissing spine, or you want to diagnose the cause of your horse's back pain. So how do you do that? We always start with a really good clinical exam, looking at muscle symmetry, doing those mobility tests. And I do caution people, if you run your hands down your horse's back every single day and push on their spine every single day, they're going to give you less and less and less of an authentic read to how their back feels. We do support doing those belly stretches and things like that, but I always tell people to take it with a grain of salt when you're palpating your horse's back, that repetitive palpations, especially if they're already agitated in a mood, might not give you the same read as a baseline mobility test. So if you go home tonight and run your fingers down your horse's back and he makes a weird face and pins his ears and dances around, that is not a diagnosis. You've kind of got to separate personality and reactivity from true functional mobility testing. We always like to see the horses move. Even if a horse might have back pain, it's important to make sure that there isn't a unilateral lameness that's leading to secondary back pain from compensation. And then radiographs. Lateral view radiographs will show you the alignment of those dorsal spinous processes. Depending on the body condition score of the horse, you can usually get back to the lumbar in most, but sometimes we're really inhibited by some of these bigger warm bloods from being able to get all the way back. And we do always take pictures of the vertebra as well, because it's important to make sure that you do not have changes in those, because that does change the horse's prognosis overall. If we want to take it a step further, then we will do an ultrasound of the entire thoracolumbar area. This allows you to look at the muscles in the back, so those epaxial muscles, the multifidus muscle, as well as evaluate for any sort of joint arthritis that you might have in addition to or in exclusion of having kissing spine. All right, so you've taken the radiographs. You see that there's decreased space there. Does that mean this is why your horse has back pain or is bucking when you pick up the canter? It does not. So it's important to separate identifying pathology and or abnormal bone, tendon, ligament, muscle findings, and then having clinical relevance to whatever you have identified on your exam. So there's all kinds of ways you can go about that. If you have a really complicated case or a lot of issues that you find on a horse, then you can send them for a bone scan where they inject them with a radioactive agent that in bone that has a lot of inflammation, bone turns over more when it has inflammation. And so if that is an actively inflamed bone, it will pick up more of the radioactive isotope from the bloodstream. And then when you go through and take pictures of the different aspects of the body, those active areas will light up more than non-active areas. And you can see also you've got some activity in these joints as well, in the back joints as well. So that can be a way to prove that it's active or or inactive. Thermography is a really hot topic right now. You'll see a lot of people talking about doing thermograms on their horses to find out areas of heat and pain. And so obviously this is considered a normal back. It is normal to have increased heat along your spine, along major vessels, etc. But you can see this horse has kind of heat throughout all the muscles and then isolated heat along these dorsal spinous processes and the associated muscles with those active areas. The problem with thermography is you have to start at a baseline. And so if you're trying to use thermography, let's say you're trying to find out if a horse has heat in its foot, you can ice both front feet. You can wait 5 minutes with ice on, you take off the ice, and then you take your thermography picture. And now you have put both of those feet to the same temperature. And then you take a picture, and if there's heat there, you know that that heat is real. But in these thermograms, you have no idea if this horse just came in from the field and was bucking and playing and rolled on a rock. So it can, these are helpful and make cool pictures. But I always take a thermogram with a grain of salt. If I'm highly suspicious on a clinical exam and my radiographic and ultrasound exam, and then we see something like this, that's 3 things that are pointing you towards, okay, this really is what we need to be focusing on. But I would say the majority of the time in our practice, what we do, because not everyone wants to send their horse for a bone scan, thermograms are few and far in between. So a lot of times what we'll do is we'll use treatment as a diagnosis. So you all might be asking in your heads, why don't you block the back? You guys have probably seen people block your horse's feet out or block a hock joint or a fetlock joint. The problem with that is when you look at a horse's back here, the muscle that sits right here, so these muscles are your epaxials or your erector spinae muscles, the extensors of the back. This would be your dorsal spinous process, and your joint is down in here. This is an abnormal ultrasound, so it's not the best example, but this multifidus muscle that sits right here is really important for proprioception in the horse. So if you kind of think of balancing on one leg and somebody comes and pushes you on one shoulder and your back engages and brings you back upright, that's a proprioception input from our multifidus muscle saying, oh, your body's going this way, we're going to engage that muscle and bring you upright. So there are lots and lots and lots and lots of nerve fibers that run through this multifidus muscle. It has a very different appearance than other muscles because of all that. And so as a result, if you're going to go in here and if you're going to inject carbocaine around all this bone remodeling and this huge hunk of calcium right here, or if you're going to block the facet joint as well, you end up with these swaying, funky looking horses. And I have yet to see one that I can confidently say, oh, your horse moves better having done that. So it's not a great area or confident area to block. And then you're still spending all the money to the ultrasound guided block. So why not go ahead and just treat the area and use your treatment as a form of diagnostics? So to go back to the point is, don't just treat the radiograph, but your actual patient. Make sure to look at the whole patient to ensure that this is your primary concern for back pain. And this is also why it's so hard to predict just based on a radiograph if that horse is going to need treatments and what degree and how frequent they're going to be. But this is me injecting a back on a horse. And basically what we do is we use the ultrasound to get this image. And then we direct the needle right through here down to the joint. And as we pull the needle out, we'll put a little bit of diluted steroid down into here, a little bit of steroid down into here, a little bit here, and then a little bit at the top to kind of also help with superficial nerve fiber stimulation. So, and if the backs are really bad, sometimes you end up having to do a few different needles because I wouldn't be able to pass a needle through this. This is bone and calcifications. And so sometimes it can be a little bit tricky and you end up having to maybe put a needle in this direction and then send a second one down to the articular facet. And you don't know that you have to do that unless you ultrasound it. So treatment options. So you've diagnosed it on radiographs. The horse is very clinical, both on palpations and under saddle. And you feel like this is the area that you need to treat. So what are we going to do? One of the things that you'll find is a lot of people will put their horses on muscle relaxants or methocarbamol if they feel their horses have back pain. And there are hundreds and hundreds of studies out there that go to show that methocarbamol has a very minimal effect on true deep back pain. And that goes back to the point that this muscle down here has so many nerve fibers that if you have all this remodeling and active inflammation within this muscle, it is constantly saying, ouch, 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 ouch. And a systemic muscle relaxant might make this muscle up here feel better, you know, these large mass muscles, but has little effect on that proprioceptive muscle. Not to say that it's not useful, it isn't helpful. If they're really, really painful, as a little bit of a self-preservation, I will often put them on methocarb for a few days before we come back to inject them or before we do inject them. And that's, you know, just so that the procedure goes better, so the horse themselves is a little more relaxed, because the muscles will be very tense in the more clinical cases. Shockwave is one of my favorite ways to manage backs. It has, among various studies out there, documentations, retrospective, whatever, continues to show a really good response to this therapy. And so shockwave is basically extracorporeal shockwave therapy. And it is a combination of electromagnetic and sound waves that can travel through the skin depending on the various depths of the skin, depending on the probe that you are using. So we'll use an 80mm probe. We usually do about 2,000 shocks, and we'll go on the entire thoracolumbar area, muscles, midline, and the muscles on each side. Even though this has a really good response, it tends to work best if you have less than 4 vertebrae involved, and or if you're using this in combination with injections, or say on a post-op kissing spine horse to kind of help manage some of the chronic muscle changes. But usually when you have more than that, I find it's very, very variable on how long of a response you'll get from the shockwave, because this is temporary. We are removing and managing pain doing this. And so usually it requires a series of it, or intermittently used throughout the year, maybe after a big competition or before a big event, or a fox hunting season, etc. And so it's a great adjunctive therapy to other forms of management. Mesotherapy is also awesome. That is what this is. And mesotherapy is a combination of, we used to use a medication called Serapin, which is an all-natural product that acts as a nerve block. And it is not available anymore. So now we tend to use a combination of steroids and a regional analgesic. Some people put vitamins in there, some people dilute with saline. It changes depending on what the drug tests or how close to an event you might be, but you use these series of diabetic needles to go into the subcutaneous skin and put this product all along both at the area and just behind the area of pain. And without getting into nerve fibers and translations, basically what this does is, if you think about when you burn, if you touch a stove with your finger and it's hot, think of how quickly you react to that. But if you, and I'm sure we all have, burn the side of your, neck with a curling iron, you might say, oh man, I did that, but it's not quite the same knee-jerk reaction. And that's because the nerves that are further away from the spinal cord have more sensitivity. That makes sense, right? You don't want to bump into things. You don't want to get hurt by something. If you are starting to get hurt by something, you want to be able to react for protective purposes. And so what this does is it helps block some of those more superficial nerve fibers to help decrease that pain pathway back to the central spine. And it sounds a little voodoo-y, but it works really well for necks, for backs. You can't really use this on the distal limb. There's people out there who have tried it over suspensories and things like that. You don't quite get the same effect. And I think it's because you don't have the muscle mass above the area of pain. Plus you can reach that area so much better. We already kind of quickly mentioned ultrasound guided injections, and then bisphosphonates or OSPHOS, which is an off-label use. And this is a drug that works at the level of bone metabolism, and it helps to regulate the breakdown of bone by blocking osteoclasts. And there are more and more emerging studies showing that it has a large effect on bone pain, and that it helps with the breakdown and the interspinous ligament dorsal spinous process relationship there. And so it's been shown to really relieve back pain secondary to kissing spine. And then surgery. Hot topic right now, kissing spine surgery. So there are two types of surgery out there. You have the more simple interspinous ligament desmotomy, where they go through and they cut this ligament I was talking about that runs between these dorsal spinous processes. By cutting that, you're doing two things. You're increasing the space between these, because as that back, remember, either flexes and extends, this ligament that pulls this process together is cut and not there. So it kind of decreases the dynamic aspect of the impingement, but it also cuts that nerve I was talking about. So you're both doing a nerve, I don't want to say neurectomy because that's also a trigger word, but you're doing a little bit of nerve modulation as well as increasing that space. These are done standing. They go through and they cut from the side. They do not go through the supraspinous ligament. And that's important because in the older spinal surgeries that they used to do for kissing spine, they would come from the top and actually cut off the whole top of this so that you did not have anything even capable of impinging. And there was a lot of post-op complications with those. And it was decided it was from going through this ligament up top. So I would consider this in the greater scheme of medicine a new surgery, and the even newer version is this cranial wedge ostectomy, which is a mouthful, but it's used in the more severe cases. So when you start to get these overriding spinous processes like this right here, where it looks like one is literally kind of burying itself into a little canyon in the one before. So we call this overriding, rather than this is more kissing or impinging. And by doing this, not only are they cutting that ligament to provide that nerve pain, but they're actually reforming the shape of this bone so that when that spine does extend, you no longer have the ability for these to impinge on each other. And this is a longer rehab period, which makes sense. One is just cutting a little ligament. The other one is cutting a ligament and cutting a bone. So I simulate this when I'm explaining it to people, kind of like the TPLO surgeries that your dog will get if it has an ACL tear. So they literally go in and they make the round tibia flat, so that the ACL can repair. Alrighty, so this is just a more recent case that we had. This horse was having no lameness, no issues jumping, was doing fantastically. I don't think that's a word, but was doing fantastic. And the only thing he was doing was bucking, but the bucks were getting worse and worse and worse and worse until the eject button started to be hit more often. And we ended up diagnosing him with kissing spine. He actually responded beautifully to injections, finished out the rest of the hunt season, and then we just had his surgery done. And you can see, this looks like a pretty serious back. And, now it's no longer going to be an issue, at least the impingement will not be. And we felt confident doing the surgery because of how well he responded to the injections. So I won't harp on this because I want to get to the cases, but we use a Pessoa rig in our rehab. Another thing that we sometimes do is send horses to the aqua treadmill. The water, helps them to have to engage their muscles a little bit more because of the buoyancy without impact. And then if you've had multiple vertebrae, like more than 5 vertebrae done in the ostectomy, we tend to give them a little bit more time to heal until we start doing all the rehab. So, but this Pessoa rig is great because what you're doing is, although you're limiting the horse's ability to put the head up, you're not tying the horse's head down. This horse is learning to stretch down into this rig. And then the strings back here help to keep the hind end engaged. So you're elongating the muscles of the top line. You're elongating the muscles of the hamstring. You are building the psoas because of the constant flexion, and you're strengthening the core of the horse. So it's a really nice it's a really nice tool that we incorporate. And I think it's so important to have a good rehab program after any injury, any surgery. All it does is increases your success. But I do think that some of our more behavioral back pain horses, this is a really beneficial tool because it can dissociate back pain from being ridden. If you spend a month working on a lunge and a Pessoa rig, building all these muscles to help support the surgery that was just done, it can kind of help that horse, dissociate pain from work, which is important when we can't tell the animal that it's not going to hurt anymore. So, and then any injury, any issue, there are long-term exercises and ways to help manage it. And for the back, it's all about physiotherapy and exercise, encouraging them long and low at the beginning of any work, really good warm-ups, cantering before you start doing all your collection work, Carrick stretches, ab exercises, cavalettis, back on tracks, beamers, theraplates, those all help just maintain healthy muscles and blood flow and are good tools in between treatments. Okay, so on to the cool stuff. So this is my first case I want to show you guys. And this was a really cool one. A younger thoroughbred steeplechaser, lightly raced. And primary complaint this trainer had was that this horse was really objective to going up hills, which is kind of important when you race on them. Normal going downhill, but just shutting down going uphill, and also starting to have more and more issues going over the jumps if they weren't going at an all-out jump schooling speed. And in the arena, noticing that the horse was having difficulty with shorter distances and arching up and over the jump. So when I looked at the horse, there was some reactivity to a small area in the back, pretty painful to lateral mobility, but the most significant response I got was when I asked the horse to flex and extend the sacroiliac area. And then we saw Horse moved around in the arena. Lovely mover, very balanced, very happy, both in the arena, on the grass. And then we got to this part. And, you know, you can see the horse is not lame. The horse accepts the bit, goes into the bit. And then the second we start to get this incline, even off of the horse's back, he starts to go sideways. He starts to object, breaks into the canter. Remember, that's an easier gait for the back. And then at the top of the hill has a nice, lovely balanced canter. So we did it once without the rider. Not because I like torturing clients running up hills in the middle of August, but you can see that the horse is much happier. Still stagnant is not, you know, I didn't include all the other videos because we have limited time, but you can really see the difference in the horse's willingness to go uphill with a rider versus without a rider. So to decide, do we address the back? Do we do the pelvis? We did radiographs and a transrectal ultrasound. And these are the radiographs of the back. Not very exciting, right? You have this one spot right here that has a pretty big override with the other spinous process and this black hole right here. And that's it. And I did find some arthritis in the SIs, so I started by treating the horse's pelvis. And the trainer called me back a month later and said the horse is jumping phenomenally, but I still can't trot him up hills. So I came back and I treated the back. We treated this space, and this space, as well as there was some arthritis down at the bottom too, very slight though, and responded beautifully. 2 weeks later, was trotting up hills without any issues. She maintained them with chiropractic, core exercises, started to incorporate some Pessoa work on days as well. And he ended up having a good race season and being sold as a fox hunter and has not needed any treatments for almost 2 years now. All right, this is another case. This horse is an 11-year-old thoroughbred, and she was becoming very objective to work under saddle, and it was becoming worse and worse and worse. She was bucking, she was exploding, she would try to graze, and then when you asked her head to go up, she would scoot off in a pain response. They were getting absolutely no differences if the mare was on bute and Banamine and methacarb. They tried hormones, they tried gastric ulcers, Lyme's, all of these things were completely negative. And the horse has no history of lameness in the past. And so you can see this horse's top line is very poor. There's this huge divot right here where there should be a nice epaxial muscle. And then you can really see, I'm gonna mess this up probably. Haha. No, no. Where you can see the actual bones of the top of those dorsal spinous processes. And that's not because the horse has really high DSPs. That's because the muscle that originates here, your middle gluteal, is so weak that it's not covering the sides of this horse's skeleton up top. So they did not want to ride her for me. No shocker there. And you can see she's just kind of not going anywhere. She's agitated. She doesn't want to go forward. She's swishing her tail. And what you can really see is when she puts her head down, she moves nicely. And then her head flips and she comes up and she shortens behind. She sways out her hind end. And she's visibly uncomfortable and very difficult. We could not get her to canter on a small circle. And this is my least favorite thing that I think I've ever done, but I wanted to see her canter, so they free lunched her. I do not recommend this. And still, the mare is running free in a field, and this is her stride. She's got no dissociation. She's super choppy. The head doesn't move. And look at her in this turn. There's no bend. She motorcycles around the turns while we were evaluating her. And I thought this was a cool freeze frame, because look at how straight her back is. There is no flexion from the base of her withers to her croup. There's no extension. She is 100% guarding her hind end. She's extending her head to try to decrease the extension through the back because she has her head up. And then you can see how much she's about to swing her legs over rather than picking them up and placing them and flexing through this top end. So she had some pretty significant changes through her thoracic area and into her lumbar area a little bit. She had a total of 7 vertebrae involved, and given the degree and the amount of them involved, the owner elected to do the surgery, mainly because of finances. It is not an expensive surgery in the greater scheme of the equine surgery world. And it's usually only a few more $100, depending on which one you're doing, than injecting the back. And the mare was becoming so violent. I really wanted to take, especially this area right here. I mean, it almost looks like it's fractured there. I really wanted to take this off the table since they were becoming really frustrated with her. And I figured she could only benefit from the rehab and a Pessoa rig. And we also treated her for ulcers afterwards. So she had the ostectomy procedure done. I do not have her post-op images. I tried to get them from the owner, and but regardless, she is doing really, really well since her surgery in 2020, and I haven't had to do anything since. Both the owner and the owner's mom have been riding her without any issues, so they are very happy with the outcome she's had. She's also fat now. And those of you who know me know I'm a fat shamer, so I'm not being mean. Alrighty, case number 3. And if people have questions, you can speak up and I will try to stop and answer. We can always answer things at the end. Okay, so this is an interesting one. So this is a 5-year-old thoroughbred. She bought him as a 3-year-old to fox hunt, and I thought she had a brain tumor when she told me she was buying a 3-year-old to break and train herself to fox hunt. But regardless, the horse is lovely. He's been fantastic. She hunted him really well for the last 2 years, but he, over the past year, has started to show some objective behavior. He's very difficult in his transitions in the ring. He's very reluctant to move forward. She describes him as lethargic under the saddle, even on colder days or in the winter. And he was also starting to show some aggression to horses that were in front of him on trails if they were on uneven terrain. And I had seen the horse multiple times for an intermittent front end lameness that usually occurred after several days of work, in particular jumping in a row. And I think I saw him twice. Both times by the time I got out there, the horse was sound and moving around the lunge line cool as a cucumber. So third time I was out there, I was like, we're going to do some stuff, because clearly the horse is having some performance issues and isn't maintaining a consistent exercise schedule. So I did the horse's pre-purchase, and I've worked on the horse for over, for 2 years. This was the first time that he was significantly reactive and repeatedly reactive to midline palpation. and quite reactive to lateral mobility. And then when I took a step back, sorry, let me rephrase that. When I took a step up onto a ladder and could actually see his back, I realized how poor the muscling was where the saddle sat across his top line when the horse was very well muscled in the rest of his body. So we can watch him go around here. And so this is a blistery day, and he is barely moving forward. She's got spurs on, lunge whips. You can see him kind of shortening and pinning his ears when she goes to do the sitting trot here. We like to see horses on the correct diagonal sitting trot, wrong diagonals, to see if that changes any of their presentations. She's adjusting her spurs so she can actually canter. And the horse isn't lame. He's got a nice walk. He's very guarded underneath the saddle though. And then you'll see through here, he goes to pick up the canter and he just shuffles into the whole thing. There's no rock back. There's no balance. The canter is the easiest gait to see flexion and extension in the back because it's on the same side. The two sides of the horse can work together. And, even here, you just see his hind end pointing up rather than arching around. So, not a very exciting horse to look at. Most people might just say, oh, you need to get him fitter or bigger spurs. But, for a 5-year-old thoroughbred who's inconsistent work, but not overworked, this is not normal. I didn't have a coin this day, so we had to use a battery. But the reason I put this here is whenever I take a radiograph after doing an exam, I will usually put a coin, not a 9-volt battery, on the horse's back to mark where they first dip away from my pressure. And I think that's nice to give your clinical exam a radiographic relevance. So right where he dipped away behind the withers, you can see that we've got some narrowing here, a lot of narrowing here, and just the start of some overriding on this process as well. And you can even see how, even though this is close together, not touching, you can see how when this horse extends its spine, how this is digging into the back of that to create this divot and bright white, which we call sclerosis. So being the fact that this was a 5-year-old horse, she elected to go ahead and, it was in the fox hunting season, and decided to go ahead and proceed with the surgery. She didn't want to be injecting a 5-year-old every year for back pain if it came to that. So pre-op, again, our spaces here, and then post-op, you can see not only how much wider the actual spaces are from cutting that ligament, but the fact that when this spine goes to extend, there will be no contact between these DSBs. And he's in the middle of his rehab right now, but doing really, really well. She had her first week of riding, and she has decided she needs a stronger bit. So I feel like that's a good sign. Okay, so Polo Pony, 10 years old. She was rehabbed for a stifle injury very carefully. And after all that rehab, they noticed that her top line was not improving. And the owner was continuing to feel a shifting lameness between the hind legs. And then days where she felt so stiff behind that and unright up front that the owner actually got off and would just pony her instead of being on her back. And she would move out, symmetrically, really forward, very happy to be in work, not taking any crab walking steps. And then she would get on just to see how she felt after ponied, and same thing would happen. So you can kind of get the theme of how these horses palpate. She was reactive. But I want you to see how forward, how symmetric she is behind, how good of a mover she is. I mean, you look at that horse and you think, gosh, there isn't a problem around. And then we have the rider get on. And she's a little stiffer behind. She's very guarded, if you see, with her head. She was forward and fluid in hand, and now with the rider on her back, that head really doesn't move. And then we'll have, you'll see the rider will get into 2-point, and instantly she starts to scoot forward. And, you know, now he's having to kind of half halt her, and that trot just really, really frees up under saddle. And then he'll sit back down and you'll see her flip her head. She actually takes an abnormal step or two with her front end, where I almost thought she was going to start presenting a front end lameness, but quickly worked out of it. And canter did not improve that. So shocking. She had some impingement starting right at the area where she was most reactive to back palpation. And it's not horrible. We have just a loss of spaces with some bony changes on each side. So we weren't, you know, because of the shifting leg lameness and the recent stifle injury, we were not convinced that this is what, you know, was constantly presenting to the owner, but clearly it was bothering the horse and clinical enough that we went ahead and treated it with ultrasound guided injections. And one of the reasons that we are continuing to treat this horse with ultrasound guided injections yearly, and the owner has not done surgery, is because we have so much remodeling and muscle change. So this is a really normal, so this is the same horse, left side, right side, normal dorsal spinous process, beautiful multifidus muscle, nice bright white bone reflecting back up, you know, homogeneous muscle. And then we go to the left side, and this is just, you know, all this remodeling. I mean, it does not look like the kind of slide that you want to go down on the playground. And as a result, this muscle is very abnormal and even has kind of some areas of fluid in it, but also this paxial muscle isn't normal. You know, you have some calcifications in it. It is larger than this side over here. It's more disorganized and has some fibrosis in this muscle pattern. So whether this is from an injury, whether this is from chronic, you know, abnormal and compensatory movements that this horse has done, you know, we won't know. She'd never had been evaluated for kissing spine. It was not an issue at the time of her pre-purchase, but at the time of her pre-purchase, she had been out of work for several months. And so we maintain her with injections because there's more going on to this filly than just pain from impingement. And so even if we went to the surgery, you would probably still be treating these muscles and injecting some of the other more arthritic areas in the back too. We treat her once a year. We inject from T10 to T17 with a steroid or orthobiologic. And
in the drawer, like
they've changed her fitness program. So they pony her often. They really make sure that she is fit going into the season, and she gets 2 to 3 months of rest. And I think this is important because, you know, when a horse during a pre-purchase does not show you any sign of back pain and the horse has been out of work, well, then that is telling you that this horse responds well and can reset with rest. You know, resting a horse with back pain, the hard part about it is it takes several months. It takes at least 45 days, they say, to let wind up pain to decrease by at least 50%. So it's hard when you have an athlete or a young horse in training to just stop doing what you're doing for 2 to 3 months without a specific diagnosis. But this protocol is working beautifully for her. She's playing really well. And, you know, this is an example of how important it is to have a complete diagnosis rather than just taking that radiograph, sending her for surgery, because there's more to treat and there's more causes to this mare's back pain than just impingement. All right, so the last 3 are really fast. I am a talker, I apologize, but I don't have great video on these last few horses, and I had a feeling I would be talking too long, but you can see how poor the top line is on this horse. This is a steeplechase racehorse, a successful grade 1 racehorse. He was retired and went and became a fox hunter. The horse had been treated by Dr. Williams and myself for the 5 years he was here racing in the States, and never once did he say, "My back hurts." We maintained his pelvis, his neck, and some other things, but never once his back. And then one day he had a rotational fall out fox hunting. He came in from the fall very back sore. And so I was worried about a fracture in his withers. He was that painful. And I found this. So lots of overriding in multiple processes, you know, impingement all the way back here. So this entire area of this horse's back is, whether he's flexing, you know, this is one of those where a lot of times when they flex, they can get relief. But whether he flexes and this moves up, or whether he extends and this goes down, you know, there is no stretch and recoil in these DSPs. He was given rest, gets an intermittent shock wave here and there, and is maintaining very, very well with minimal intervention. So again, a big focus on fitness for this horse. This is a more dramatic one. So this horse I saw as a pre-purchase exam. He had been eventing and fox hunting a lot. The horse had a hard life, you know, not a hard life, I shouldn't say hard life, but was used a lot. And look at this horse's conformation. I mean, if that doesn't, you know, if you had to pick out of a deck of cards a horse in these cases that was going to have kissing spine, you would vote for this one. And he was starting to shut down fox hunting and cross country. But I mean, he is objective. He doesn't want to move forward. He's getting to the point where he didn't even want to work, you know, on the lunge line, you know, being ponied, anything. And you never see him actually bend through this back. And you can really see how poor his muscling is up here when clearly this horse is being fed. Clearly this horse is fit. He's very well muscled everywhere else. He's just ready to collect some rainwater on his back. Per the seller, he has no history of lameness, has had no treatments besides Adequan for the 10 years that he's been in work. And you can see here, he's just, I mean, it's like his hind end and front end are on 2 different tracks, cross canters. And that's not specific to back pain, obviously. He was quite reactive to his pelvis as well. But given what we saw here, I actually started by radiographing the horse's back and found this. So he had at least 6 spaces involved. And even with sedation, us pushing on his back or doing anything on his back, I couldn't keep the coin on his back. He would start shaking it off and twitching it off. He was that reactive to things going on. And clearly, you know, I ended up consulting for the owner after this finding. The horse was not purchased. And we determined he's not a candidate for surgery. There's just too much remodeling, too much change here. I somehow managed to get his back injected. It was not my most accurate procedure, but got it done. And the horse was okay, better. If he was showing improvement, we were going to plan to inject his pelvis and just kind of help him be more comfortable overall. But within 2 months, he was painful again on his back. And so they just elected to go ahead and retire him since the behavior was so explosive. And that's actually the least, that's of the cases I've had, this is the one that we really haven't been able to manage. And I wonder if, I'd met him several years ago, could this have been, slowed or managed better? If he's just shutting down mentally. I mean, there's a lot of questions when you look at a horse like this, besides, we tried, so as significant, this is the most significant back I've shown you guys of all the x-rays tonight. And so obviously when you have a back like this, I say you can't correlate the radiograph to the clinical signs, but when they are severe like this, chances are this horse is going to have pain and need management to keep performing at the level that is expected. But to end on a happy note, this is a horse I did a pre-purchase on. I mean, you certainly don't look at this back and think, oh man, he is poorly muscled. He has issues up here. He had no reactivity, beautiful movement through his back, flexion, extension, very round jumper, very balanced under saddle. And in his pre-purchase radiographs, which we commonly include the back now, you can see he's got, narrowed spaces, really starting in the back of his withers through T18 in the first lumbar. And some areas are worse than others. I mean, a little overriding here and sclerosis here. Not as simple as the first case I showed you, but if you saw this, you would be concerned. And the horse continued to compete for several years for this owner at the A circuit level as a show hunter. Even though we treated other things on him, for his back, the only treatment we ever needed to do was mesotherapy and shockwave. Did not inject his back, did not pursue kissing spine surgery because based on our exams that we did on him and how he presented clinically, he was not telling us there's back pain here. So let's wrap it up. A good night kiss. Basically, it's easy to see if your horse has kissing spine. The hard part is what role does it play clinically right now? If your horse is showing signs and or in a pre-purchase setting, what role will it play in the horse's athletic future or goals for his future? And really that comes down to a good clinical exam, a radiographic survey, or just preparing yourself if you found it that, there are certain exercises you can start incorporating early into the horse's training, and awareness of how the horse is using himself and how his muscling looks to stay ahead of back pain and supporting the back. And then if it does start to show itself, and you've ruled out saddle fit and ulcers and other issues such as just fitness, then you've got a slew of treatment options. But it is important to have a complete diagnosis and exam before you decide how you're going to treat them so that you have the best management plan. It's dynamic. It's going to change over time. You can't predict how quickly that change will come or evolve, because the horse is a master at compensation. It's amazing how much they can change their body, contort their movements, engage different muscles or areas, and the back is a major compensation point for the rest of their body. Caudal neck pain shifted to the back, stifle pain shifted to the back, so, and then most likely SI and or lumbar pain shifted forward into the back. So it's once they can't find this compensation anymore because it itself hurts, or if you're starting to do specific movements like lateral work or going down hills or collections and extensions and more transitions, these specific movements might elicit pain in that area. And, then they want to inhibit engaging that by avoiding it. I don't think it's the kiss of death. I don't think it is an end to an athletic career, but I do think it is something that when buying a horse, and or when you have a horse with it, there are so many options that people forget to consider for management that doesn't involve a vet. And there is also always surgery. So, are there any questions?
Awesome, thank you. There is one question from Dawn. She's asking, would a thermogram taken before work, immediately after work, and then some periods of time after work be helpful?
Good question. I think when you're using a thermogram, the most important part is that each time you measure the back, you have the exact same circumstances. So when we have used thermograms, I tell people to leave the horse in the stall, let them be, no blankets, nothing on, no movement, try to get them as cool and normal as possible, and then take your baseline thermogram then. And try to do this at the same. Horses are, constantly digesting. They're very metabolic circadian rhythm horses. So it's also important that you do it at the same time, since our body temperature is on a circadian rhythm. So if you take your baseline at 8 a.m. and then the next day you take it at 1 p.m., you're probably going to have a different baseline measurement that could be misconstrued for post-work inflammation from the day before. So let them be, do the same time, ride the same amount, ride the same, difficulty, which can be hard in itself, and then, take it at the same times after, to see if you have areas, because there are parts of the body that are going to work harder when you do certain movements. If you're going to go out there and do lateral work, then your middle spine is going to light up more after that kind of work. And it's, so in those cases, you want to watch it cooling down, and you want to watch it cooling down appropriately over time. And then, so however you use the thermograms, you've really got to treat it like an experiment. Take yourself back to high school chemistry and really try to make sure you can control as much each time to do it, to make sure that what you're seeing is real. And then the other thing is a pattern. You want to see a pattern. And if that pattern changes, or if the pattern's abnormal, then that's more critical. That helps.
Thank you. I don't see, does anyone else have any questions? Unmute yourselves and ask.
The key to unmute.
No, they're all very quiet.
Yeah, Luna is very upset. That's my dog. She's beside herself that I'm talking so much.
Well, thank you very much. This has been great. And I will post the recording later this week and share it with everyone. So if there's no burning questions right now, I guess we can end this evening's webinar.
Everyone have a good evening.
Thanks.
Thank you. Thank you.